Okay, welcome back, clinical problem solvers. Woo! um, but thank you all so much for coming on this Tuesday VMR with myself, Austin, and Mengyu, and happy holidays to everyone. And yeah, I think our all-star Deborah's got a case today, so we're really looking forward to solving it. And yeah, we can get started whenever you'd like.
Okay. Hello, everyone. I'm Deborah. This was a case that I won from Santa, so let's see how it goes. Let me start. So it's a health 26-year-old male presented to the emergency room with shortness of breath and chest pain. And while he was waiting the chest in the from the north. No, Yusuf, I'm not in the North Pole. I'm in North Carolina. Sorry, I got distracted. So, and while he was waiting the emergency department, I want to share something with you all. Sorry, I will share the screen. He presented with this EKG. Can you all see?
Yeah, we can see.
I will stop here and I'll wait what you all have to say about it.
Wow, okay. Santa coming in hot, but I think this is a young, otherwise healthy person. So it makes the onset likely acute. Most young people, unless something is really wrong, really don't seek emergency care. So the symptoms are probably pointing us to the cardiopulmonary system just because of base rate. And then we get this EKG, which is just on first pass, I like to think, is this abnormal or normal? And clearly this is abnormal. And the question is, what exactly is going on? So I think I just take a systematic approach to the EKGs, and if I look at the rate, it's 4, 5, 6, 7, 9, 10, 11, 13, 14. So if I can do math rate, is like 80 something. And then what really strikes me about this EKG is that there's bigeminy. There's a regular beat, and then there's what looks like a PVC, and a regular beat, and what looks like a PVC. Otherwise, whenever there is a sinus beat, it looks like there's a P before every QRS, and there's a QRS after every P wave that we do see. And then the morphology of that, I think I notice in leads 2, 3, and AVF that there's pretty significant ST depressions on the regular beats, and that actually sort of makes its way out through most of the precordial leads, whereas AVR, you have ST elevation. And then there's PR, maybe some minor, I don't know if I see significant PR elevation. And then I'm probably missing some other things, but I guess in short, young man coming in with more acute onset chest pain and dyspnea with an abnormal EKG notable for a bigeminy, and then also diffuse ST depressions with yeah, I think that's what I would say, but I'm sure I'm missing a lot of things. But Austin and Mengyu, why don't you come and save me here?
Yeah, what a case is already on fire, Deborah. And I totally agree with Alec. I think it's really focused on cardiopulmonary, and with the EKG especially. I don't have too much to add. I think frequent PVC bigeminy which will make me think about structural heart disease or electrolytes. But I think with the symptoms, structural heart disease, or including acute events like ACS, would be high on the differential, even though considering his young age, that would be a little atypical. So kind of have to dig more into the history and the progression of the EKG and troponin tests, things like that. But I agree, there's I think T-wave inversion, ST depressions in kind of a pattern of 2, 3 AVF, but also the anterior lateral leads kind of diffuse. I think, yeah. I think I'll pause here and see what Austin has to add.
Yeah, wonderful. I don't think I have too much to add here. I think if I take a step back and maybe do, you guys already talked about the EKG a lot, but if I take a separate approach, we have a 26-year-old with ectopy. I mean, let's just keep it pretty general. An uncommon scenario, at least that I would encounter, a young person encountering ectopy would be pretty uncommon, though there are some certain scenarios that we think about. I think we can, in order to approach it, I think we can sort of lean back on our, I think Reza, or one of I can't remember her name, she shared with us about younger patients coming in and there's like bad genes, bad luck, and risky behavior. So, certainly could PVCs represent a structural heart disease? I suppose it could, but I think we'll need some more information before we're going to be able to make that leap. Bad genes, bad luck, those sort of go together in this particular scenario. The risky behavior, I think about the times when I've seen young patients present with arrhythmia. Almost always there's some sort of substance or withdrawal exposure that's resulting this to happen. So either electrolyte derangement, as someone already mentioned, alcohol withdrawal, and then substance use. And then in particular, one of my own co-residents, Alec, and I used to drink a bunch of Red Bull and stuff, and gave himself PVCs, and then eventually atrial fibrillation and went to the emergency room. So those are all things I think are considering that in a young person. And as far as the EKG itself, as you mentioned, the only thing that really stood out, I think it's hard to make, on such a compact EKG, it's hard to make a lot of progress about the ST and T wave changes. We definitely should interpret it exactly the way that you did, but with so much of the PVCs being such large amplitude, sometimes that can derange the ST segments, and so you have to be a little bit cautious in interpreting that. And if you go to the anterior precordial leads, usually you should see at least some amount of, with that caveat, usually you should see some amount of slight ST elevation in V2, V3, and that's absent. So we're seeing a little bit of ST depression in those leads, in fact. So if we were take this at face value, that would be concerning for posterior OMI. So that's something we'll have to keep in mind. But again, seeing PVCs present from ischemia would be something that I haven't seen very often. So, wow, what a start, Deborah. I'm excited to learn more.
Great discussion. So yeah, the patient coming from excess ingestion, he was fully alert and interactive, denied any other symptoms. And while he was waiting the ED, he developed ventricular bigeminy with ST depression. Voice control was contacted and recommended amiodarone. And the on-call cardiologist was called and agreed with the recommendations. And the patient started to be agitated after the assessment and required 8.5 milligrams of lorazepam, 400 milligrams of intramuscular ketamine, and dexmedetomidine, GTT. I put in the chat. I'm sorry for that. And the patient went to the ICU, and going for the past medical history, the patient denied any past medical history, any surgery, don't take any medication. From family history, his mother had hypertension and the father type 2 diabetes, no allergies, and deny any alcohol and any alcohol or tobacco. And I can stop here.
Wow, very interesting. And then Deborah, just to clarify, you said he took a toxin or no?
He took what?
Some sort of toxin or ingestion, or that was...
Yeah, he took ecstasy.
Oh, he took ecstasy. Okay.
Yes.
Thank you so much. And do you know when he took the ecstasy?
I don't have information, but he took and started feeling the symptoms and went to the ED. Okay, excellent. Thank you so much.
So yeah, this background history is very helpful. Again, a young patient, seemingly otherwise healthy, coming in with, we're presuming this time to be acute onset chest pain and shortness of breath. And then in addition to these cardiopulmonary findings, is now having symptoms of agitation. And I think in the setting of the stimulant use, which ecstasy is, I think that could be consistent with it. Now it'd be interesting to know exactly how many hours before he came in, did he take the ecstasy? A lot of times these other drugs can be laced with other things that you're not aware of. So there could be some concurrent toxidrome going on as well. And that is a lot of sedative to be 8.5 milligrams of Ativan, 400. I don't use a lot of ketamine, so I'm not exactly sure how much ketamine that is, but I'm pretty sure that's a lot. And then Precedex, or the dexmedetomidine, which Deborah said very well, is a drug that is a continuous drip that people are on typically in the ICU it's basically like clonidine in the ID form in a way, and just to help control some of those agitation symptoms. So requiring a very large amount of sedative. So I think what we need to determine now is this an ongoing toxidrome for something that was ingested, or is this somewhere into the withdrawal phase? And it seems like our history was probably limited because the patient was agitated and altered. So I think this is where the physical exam would be very helpful to determine, what do the pupils look like? What's the heart rate? Is the patient sweating? Are they not sweating? Are they warm to touch? Do they have a fever? Are they not having bowel movements? Like other things that could be very helpful to figure out what's going on and also to affect the management. And then I think in this situation, trying to get collateral is also very helpful. Who was with the patient at the time that this happened? What did they see them take? Did they see them not take anything? So I think there's a lot of unknown here. And in those situations, leaning into any sort of background you can get from the EMS, which Robbie likes to talk about a lot, or from any of the bystanders or the people that are around the patient, I think will be very helpful. And then sometimes leaning into the lab tests and the physical exam and vital signs will be important. I don't know, besides maybe pitting this on a toxidrome, which clinically seems to fit, but we want to be sure that we're excluding other things. Just because they took the ecstasy doesn't mean that this is necessarily that causing it. It could have unmasked something that was already there, or it could be entirely unrelated. So I think here, just signs of maybe sympathetic overdrive, and we'll see if the vitals corroborate that, requiring a very large amount of sedative. And we'll just have to see, I think, how the case shapes out, but I'm not sure that the additional background information is really changing my calculus on the case at this time. But I would love to know what Austin and Mengyu think as well.
Yeah, sorry guys, I have to turn my camera off because it was actually kicked off. I'm in a hospital, so the connection's a little poor. So I may have to intermittently keep my camera off. But yeah, I feel like Alec did a pretty nice overview about the next steps and the importance of understanding more about the history. I'm also curious if he had this happen before, and in his prior EKGs. I think it's still important that we work up as if it's an ACS, and important to get the labs. Often the initial HS trope and delta trope will be, if the patient is in an area where we have the high sensitivity troponin, then it can really quickly tell us if how high the concern with the ACS. But presumably, even with a stress on the heart, the troponin could be elevated. I wouldn't be surprised if it's elevated, but depending on the degree. And meanwhile, I think having an echo to see if there's any wall motion abnormality and any underlying structural heart disease would also be helpful to help us understand the coronary, and repeat the EKG when in 2 hours, or if there's any change in symptoms. I think I'll pause here and kind of think more about and hear what Austin has to say.
No, I don't think I have anything to add. You guys kind of really covered everything, and so excited to learn more. Deborah, let's hear more about the patient.
Okay, so I will start with the vitals. The patient had the temperature 37.6, heart rate was 90, respiratory rate was 18, blood pressure 130 for 72. The saturation was 98% on room air. The patient was general agitative and had minimal interaction. He presented no rash, no lesions. He was normocephalic, traumatic. The heart was regular rate and rhythm, no murmurs. The lungs was clear bilateral, no wheezes, no rouse or rhonchi. The abdomen was soft, non-tender, non-distended, and no hepatosplenomegaly. And neurological, he was alert, but not super orientated where he was, and no focal deficits. I can go for some labs too. For WBC, he had 10.6, hemoglobin 16, platelets 254, sodium 142, potassium 3.7, chloride 101, BUN 14, creatinine 0.79, troponin was 13. Let me see, AST 18, ALT 10. And I think I will stop here.
Okay, thank you so much, Deborah. And Jen, just to clarify, is that troponin a high sensitivity troponin, or is that one of the old school troponins?
No, it's the high sensitivity.
Okay, and that's in a normal range for your lab?
Yes.
Okay, excellent. Yeah, so maybe I can just sort of tackle the vital signs, and maybe I can leave the labs to Austin and Mengyu and see what they think. So the temperature of 37.6, that's 99.7 Fahrenheit. So a little bit on the higher end, not technically a fever, but I think there's some evidence to say that the 100.4 is a little bit arbitrary. So something I'm tracking. The heart rate of 90 is interesting. It's a little bit on the higher side for presumably another otherwise 26-year-old man. And I presume these vital signs are on Precedex, but I could be wrong, the dexmedetomidine. And one of the main side effects of dexmedetomidine is bradycardia. So this patient may actually be tachycardic and then had all these sedatives and is on a continuous drip that makes his heart rate slower. So also something I'm tracking. So systolic blood pressure, maybe not as impressive as I was thinking, but again, the patient seemingly otherwise is young. And I don't know what the patient's BMI is, but something to consider. And then very agitated with minimal interaction. And then Deborah, maybe you can clarify for me, is this exam before all the sedatives they received or after?
It was after.
It was after. So still agitated despite very large amounts of Ativan and being on a Precedex drip. So definitely very concerning for something ongoing. Doesn't seem like there's any sort of cardiopulmonary signature that we're thinking about, that we're able to pick up, on exam. So that makes you think of something that we're not necessarily going to be able to pick up. So something vascular potentially. The exam, skin is not warm, no sweating. I'd love to know what the pupils were, if they were big, if they were small, although the drugs may affect that in some way as well after they receive them. And then in these situations, when you think about toxidrome, so thinking about NMS or serotonin syndrome, reflexes might be useful as well. And whether the patient had clonus, I think could also be potentially helpful. So maybe other things that I might try to get on exam. And yeah, I mean, I think those are the things that are sort of standing out on exam for me. So maybe those few other things that I would want to look into and think about. And then also people that come down and are, come to the hospital and are altered, always taking a good look at their skin as well. Do they have any lesions? Do they have any wounds? Maybe they went to a party and put some sort of drug patch on them and they have a patch that you didn't really realize that was there. I've taken care of patients and I found stimulants in their socks. Like you just never know what you're going to find. And when the patients can't give you a history, it can be very helpful clues. So yeah, I think that's what my thoughts are on the physical exam. So I'll let Austin and Mengyu sort of interpret the labs.
Yeah, thank you, Alec. I think in terms of the lab, I think there are two things that jumps out. One is the hemoglobin is a little on the higher, it's a little bit high. So the first thought is that the patient might be dehydrated from the active sympathetic drive. And if it's chronic, then he may have chronic hypoxia, but presumably, so it would be helpful to have a baseline number. But if not, if it's acute, then I think it's more like in the acute setting. Also always keep mind open for any underlying, but in someone who's young, I think more likely at acute volume depletion. And then I think another thing that jumps out is the normal HS troponin, which is a little surprising, but I think a delta would be helpful to see if it's coronary. If it remains negative, then I think we'll have to think about the STEMI or the ST like mimics, which would include I wouldn't really think of PE given the normal SpO2, but any other like structural, I was thinking I think Takasubo, you would also see similar picture, and you could still have a troponin elevation. Yeah, I think, and then pericarditis, but I think so far it doesn't seem like there's any history or symptom that points toward that hypothesis. So yeah, I think I'm really curious what's causing this EKG pattern. I might repeat one to see. And also just going back and think about the chest pain, going back to the framework of 4+4+2 to think if, with one EKG, but normal trope, like also think about quickly just run through the 4+4+. So like ACS, aortic syndrome, I think getting a bilateral BP might be helpful, although the concerns, there's no like a back pain but I think that just keeping that in the mind, if troponin remains negative, then I think as a next step, you would get a CTA of the chest. And then, think about Takasubo and pericarditis I mentioned earlier. And then for pulmonary, think about P or pneumothorax. But again, no hypoxia to kind of points toward that. You would get an X-ray anyway as part of the workup. And then esophageal, I don't get any association with esophageal swallowing. So I think maybe less likely based on history. But I think that's where my thinking is goes right now. Yeah, how about you, Austin?
Yeah, no, both of you guys had amazing thoughts. And I think you guys are all touching on, I'm sort of struggling to understand like what problem we're solving right now. And so I think that's, the crux of what's happening. I think we have the chest pain, which, certainly is very morbid. And so we have to think about the 4+2+2, as Mengyu mentioned. At the same time, like the patient is agitated and like how reliable is the chest pain history? It's so morbid that you have to, entertain all the possibilities. But I've certainly had patients where they were sort of, lucid for a period of time, said they had chest pain, and you go down this diagnostic route and you really don't find anything. So we have to interpret it with that in mind, by understanding that anything that's particularly morbid, you're going to approach that. We also have the EKG, which we need to approach. But I think if we step back and say, okay, we have a 26-year-old man, and he's completely agitated and deranged, right? Like, how much do you have to do to your body as a healthy 26-year-old to be completely agitated? Right? There's not a lot of things that can necessarily do that. Like, we have the history of the substances here, which is a big issue, but I guess I'm struggling with the lack of really systemic signal on the vitals, on the exam, and on the labs that this is affecting his body in any other way. We really have a prominent CNS picture, right? He's very, very agitated, but doesn't really have any other peripheral signs. That being said, as Alec mentioned, we're interpreting this in the context of receiving a bunch of sedatives, so it's hard to know if that's the right diagnostic path to go down. But right now I'm kind of struggling about which problem do I solve. Do I think about the encephalopathy or agitation and approach that more systematically, or do I really hone in on the EKG and focus in on that as well? I'm not really sure, so I'd probably be entertaining both at the same time, understanding that there's overlap because we have this exposure history. Though we say we think it's ecstasy, which could potentially fit with the Sonara, but we don't know for sure if that's the only substance that was taken or the background of what exactly happened, as Alec mentioned. So, I think as far as my next steps here, I think we have some. I think we need to go after the heart in my mind. So probably going to check some more arrhythmia related things like the TSH. Usually it's hard to, we always blame the thyroid, it's always never the problem, but at least I would go down that route. I would probably check the remainder of the electrolytes that haven't been checked yet. I'd probably get an echo, as someone else mentioned. I'd probably repeat the EKG, and then I'd be thinking about his mental status a little bit more after, if we don't find anything there. I'm kind of lost, to be honest, so we'll see what problem we need to solve moving forward. So Deborah, excited to learn more.
Okay, so troponin was done again and continuing normal values. Like, I don't know if you want any more lab, but basically it was everything normal. And a chest CT was done, and the patient presented like a consolidation in the right upper and lower lobe, in the right upper and lower lobe, with no Grand-Glau's opacitive, but Grand-Glau's opacity was seen in the posterior left lobe, and no pharyngeal bodies was seen. And the patient started to be hypoxemic, and he required like emergent intubation. A mutual run was discontinued without any arrhythmias, and the patient was treated for concern for ecstasy, induced lung injury, and possible aspiration pneumonitis. He progressed to severe ARDS and was sedated, paralyzed, and prone for 16 hours. For several days, ventilator was getting gradually weaned, and he reliably followed commands and was intubated for several hours. I will stop here, and then I will continue with what happened with the patient.
Okay, so just to clarify, this is the last alcohol before the diagnosis, Deborah? No? Okay,
No.
still more. Okay. Awesome. Thanks so much. So do you have at least some sort of more signal for what's going on here? I think it was totally reasonable to get a CT chest just as in the workup for the chest pain in general. I guess I don't know if I was necessarily expecting a consolidation of right upper lobe and right lower lobe. But I guess at the same time, I'm not that surprised, seemingly with how agitated the patient is, at very high risk for aspiration. I honestly don't know much about really anything about ecstasy-induced lung injury and how that would present. And I guess I would imagine as well about how the patient ingested the ecstasy. Was it smoked? Was it snorted? You know, and I imagine it was probably inhaled if we're invoking a lung injury there. Although certainly aspiration could have happened. Now, the degree of hypoxemia that developed is very, very, very severe. But it seems like over time, the patient improved over a few days with empiric treatment and was able to be extubated. So again, just like Austin stated, I'm not exactly sure what problem I'm solving. I think there's still more clue that was it the fact that maybe the patient had an infection and that was causing the CNS agitation and related to this, or whether he had a concurrent CNS process going on at the same time and the antibiotics were just sort of helping both. But I think I'm really struggling to figure out, are we solving altered mental status? Are we solving chest pain and shortness of breath? Are we solving pneumonia? Are we solving a non-infectious lung injury? Are we solving encephalopathy from drug use and its concurrent side effects? And just with the way that Deborah is so excellently presenting the case, but there's more information after this, I imagine there's something that happens after the patient gets extubated, and presumably not something good. So I think here, as far as what I would like to know next, I think I would be curious to know, maybe see the images if we have them, you know, maybe talking with the radiologist. Do we really think this is infectious? Do we think this could be something else? Can you tell me, I need to look more up about this ecstasy-induced lung injury. Do you think this could be helpful? Can we clarify with the patient, like how they ingested the ecstasy? And then, you know, maybe sort of getting a sense of if the patient did aspirate, what sort of organisms did they have? If they didn't aspirate, the patient has seemingly been improving from a hypoxia perspective, and what have we been treating them with? And then if the patient gets worse, what were we not covering at that time? Or were there's a new concurrent process that was developing? So, yeah, I think, again, I'm a little confused, but I think time is frequently the best diagnostic test. And I think as we get more clarity on the patient's time course and we're able to better define the syndrome, I think I can speak more to what exactly the problem is and then go do a better job solving it. But, you know, beyond that, I'm not exactly sure what to do, besides to say that I think in general, for a young person that was otherwise healthy, I could imagine that the patient ingested some sort of substance, presumably ecstasy. The stimulant triggered some PVCs, and then the patient was altered enough to become altered, and then either from the drugs itself or from all the medications they received to calm them down, aspirated, ended up with a pretty bad pneumonia. Although with a young man with otherwise no clear structural lung disease, to have like ARDS from aspiration certainly can happen, but seemingly is a little bit surprising. But I will cease my rambling and see if Austin or Mengyu have additional things to add to that.
Yeah, we should have predicted Deborah has something in lung and waiting for us. But yeah, I agree with Alec. I think the patient seems to have a lot of problems that we're reading that are going on maybe in parallel, or at least I think we kind of teased out the coronary event part from this picture, and now focusing on the lung, assuming the prior presentation and are all explained by the toxic syndrome. So now I think the question is, how does the consolidation look like? I wonder if Deborah has an imaging, because when my presumption is aspiration pneumonia, and sounds like the patient improved. I need to confirm, is the patient improved with treatment pretty quickly, get extubated? But also on the other side, I think depending on how it looks, might need to talk with radiology to see what are some other differentials for that consolidation. And I wonder if while he was intubated, the team did anything like bronch. Since he's already intubated, it might be easier to do, but presumably if treating as a pneumonia and getting better with antibiotics, I think that's still the most likely hypothesis. But I think a repeat imaging will help us tell, although it takes many weeks for lung inflammation to resolve on imaging, but I think repeating imaging would still be helpful. So yeah, I think understanding the lung imaging, the picture in the lung will be helpful. And I also need to read more about the meth-induced lung injury. Don't know if it could present this way and how it's usually managed. How about you, Austin?
Yeah, no, amazing thoughts. And I think, right now we're just, and fortunately it happened, but we're sort of in management mode. The patient developed respiratory failure. It was pretty dramatic. Ended up being intubated, was ARDS, got prone, paralyzed. So, we were strict management mode, but I think we step back and say, sometimes the syndrome that the patient comes in with does not necessarily mean that's the syndrome that we are going to have to solve while the patient is in the hospital. So the patient came in with what looks like an ingestion of ecstasy, had a clinical syndrome that was seemingly consistent with that, but then has now developed profound respiratory failure. Now we can say maybe, again, I don't know anything about ecstasy-induced lung injury, so I'm excited to learn more, if that makes sense. But what have we done to the patient while they've been here that could have caused lung injury, right? So maybe in the process of sedating them, or while they were, agitated, they aspirated, but we also exposed them to medications that could cause lung injury. So amiodarone, classically associated with chronic lung injury. I think there are a few sort of like acute lung injury syndromes that can happen with amiodarone. I'm not certain about the other medications he's received. So I'd be interested in that possibility. And, while he was intubated, it sounds like they stopped the amiodarone. I'm not sure if received any other intervention. So it's possible maybe stopping that made him better. And maybe we'll hear that he had a recurrence of arrhythmia and they restarted it and he got reintubated. And I'm not really sure what we're going to find here. But beyond all the excellent things you guys mentioned, that was the only thing that came to mind. So Deborah, excited to learn more here.
Okay, so I stopped at where the patient was extubated for a few hours, and unfortunately he became hypoxic and required reintubation. A bronchoscopy was done, and what demonstrated pink tiny secretions. I don't know what that means, but if anyone can help me to learn. And then an echocardiogram was done, and the ejection fraction was 45 to 50% with a global hypokinesis in the left ventricle, likely secondary to substance abuse. And the patient improved the oxygenation on several ABGs, and he remained intermittently agitated and diaphoretic, and he was then unable to follow commands or recognize his girlfriend. So the next, Alec will reveal the diagnosis.
Wow. What a case, Deborah. I mean, I guess just to clarify, how many days after his presentation did he have this event where he was extubated and then continually got worse? What day was this?
I don't have on days. I'm sorry, but
That's okay. Was it like
he was
ballpark, like
what?
Like ballpark, was this like 3 days after he came, 10 days after he came, like randomly? Not sure, but it wasn't the day after.
No, no.
Okay, that's helpful. So I think the patient was doing well enough to be extubated, and then pretty acutely after became profoundly hypoxic again and ended up getting re-intubated. So I don't know if it was maybe the positive pressure from the intubation that was helping the patient with maybe a little underlying concurrent heart failure, and then because some of the medications that we can use and other things, maybe the patient got flash pulmonary edema and ended up getting intubated again for respiratory failure related to volume overload and pulmonary edema, and the pink secretions or sequestrations. I guess I'll have to clarify, but I do wonder if that could be pulmonary edema. But you know, I think the patient still has signs with diaphoresis and, you know, tachycardia and other things that Deborah had mentioned in the agitation of sympathetic overload. But if the patient took a substance and has been in the hospital for multiple days, why do they still have that? And I don't think we can implicate that anymore. So I think we need to entertain other things that could be causing sympathetic overdrive. So I think Austin's thought about the thyroid would be definitely something to entertain. And then, you know, other things, you know, peritoneal lung sphere, chromosatoma, other sort of weird things related to that. But with the ongoing agitation, diaphoresis as well, I do think we need to start worrying about the CNS and evaluating that appropriately. So definitely getting some baseline imaging. I think a lot of these drugs sometimes can cause cerebral edema that you may miss. So that would be something to consider. And then there was a case recently that well, at least when Austin and I were at SGIM, there was somebody that got hypercapnic, and that caused significant cerebral edema, which Robbie got right away, of course. But I think just other things in the CNS that maybe we're missing that we could potentially reverse. And the EF, I think from stimulants, that's not uncommon that we see that. The acuity of which I think is unclear. But the patient with the rapid onset hypoxia after getting treated for infection certainly could implicate a vascular cause, potentially pulmonary edema. So I'm not necessarily surprised by that, but that should get better with some diuresis and why the patient has such profound respiratory failure plus signs of sympathetic overload. I'm not entirely certain, unless we're missing some sort of infection that we weren't covering previously, or I don't know if the antibiotics were stopped at the time the patient was extubated. I think that's very unclear. So as far as what we're going to do next, if I was managing the patient, I think in addition to doing the bronchoscopy, being sure all the infection studies we're seeing, I would still, keep the patient on antibiotics, consider broadening them, covering other organisms that maybe we were missing before. I do think we should, get a good volume assessment and really see how volume overload the patient is and diurese them appropriately. And then I think I would entertain additional CNS workup and then other workup for signs that could cause sympathetic overload. So that means thinking about systemic conditions that could do that, but also thinking about all the medications that we give patients in the hospital and how that may affect things. So frequently where people are intubated and sedated, there are multiple agents like fentanyl or midazolam or Versed or other things. And a lot of times those medications in combination can cause toxidromes like serotonin syndrome and other things. So I think being really thoughtful about the medications, thinking about other surrounding systemic conditions, and then really taking a step back and thinking how much of the ecstasy is actually still contributing to this. And then what are we missing? This is a young person who had something that came in with something acute that should resolve pretty acutely that's not getting better. So we're missing something and we need to figure out what that is. And I think taking a holistic approach in that way is probably the best way to go about doing that. But I'd be really looking forward to learning from this case and also hearing what Austin and Mengyu have to add.
Yeah, I can go next. I was thinking, so I think there are two problems. One is the fact that the patient needs to be re-intubated, and the second is the ongoing agitation or altered mental status. So for the first problem, I was thinking like when the patient got extubated, he must have met the criteria, so there's criteria for doing a spontaneous breathing trial that includes the one is the underlying process is getting better, and second is the patient requires minimal positive pressure and the FiO2, and third is that he's hemodynamically stable. So I think for this patient, presumably he's been hemodynamically stable the whole time and he had minimal requirement. I think then the question is whether the underlying process has improved, and I imagine the team had got repeated imaging and to see if the consolidation whatever has improved or not. So I think that's one question to answer. and maybe the bronchoscopy that Deborah mentioned that he had will give us some answer. And the second criteria for patient to be not just if he passed spontaneous breathing trial, has to actually be able to extubate. Also requires the patient has a good mental status, that he's able to have good cough, manage his secretions, and having the mental status capability to follow simple commands and lifting heads and things like that. So I wonder if when he was intubated, maybe he got the sedation now. Usually I think the team would wean off the sedation to assess his mental status, but for some reason maybe his mental status got worse once he's extubated to the point where he couldn't protect his airway. So I think working up the ultimate mental status is important, and for that I'll activate the MIST framework. I think doing all the metabolic workup, including all the electrolytes, ammonium and thiamine, or making sure he's having bowel movements and urinary retention, things like that. And the infections, I think, is already being treated. And then I think most important is getting imaging to rule out like a structural brain, or to assess if there's any structural brain disease. And lastly, the toxin. I think I definitely have seen people who has prolonged toxic syndrome with ongoing mental status, but I don't think we should presume that was the cause. We have to kind of rule out other etiologies. And depending on how he looks, I think next step is non-MIST, like workup, like seizure assessment or MRI but I think maybe it's a little more, we have to we start with a CT scan actually. So I think those are my thoughts right now. How about you, Austin?
Yeah, no, incredible. So I don't really have anything else to add from what you guys said, and I'm just like, Deborah's stretching me so far in this case, and so I really like it, and I'm really excited. I'm going to watch this VMR like over and over again, because I'm sure there's like so many little pearls that she stuck in there that I didn't pick up on. But I think the only sort of other thread that I really thought about beyond what you guys already mentioned is like we do have the global hypokinesis. And as Alec mentioned, we could have, there doesn't seem to be a history of chronic substance use, at least that we've gotten, but it doesn't mean it's not there for whatever reason the patient feel comfortable sharing with us, or we weren't able to obtain an accurate history. But there could be a chronic component, but also in someone that is this stressed, I would not be surprised if they could have a stress-induced cardiomyopathy right there in and of itself, right? So when someone's EF is low, usually it would need to be lower than 45 to 50%, but always thinking about, could this person have developed a thrombus and then embolized to the brain? And that's why we're having persistent CNS issues. Like, I don't think that's the scenario that we're in right now, but that was one thing that came across my mind. The other thing was, as Alec mentioned, most substances should go away at this point in time. So maybe there is a second substance that was present that we're missing, or there is a withdrawal now on top of the initial substance exposure that we're seeing, like from benzodiazepines, for example. But again, we don't have updated vital signs, but we're not really seeing like the systemic signal for that, which I'm still struggling to reconcile. Like, we have this profound CNS derangement, but not much systemic signal. Again, it's sort of the caveat that we're receiving a bunch of sedation, so it's hard to make progress on that potentially. But these are the things that will be crossing my mind in real time. So the other thing that I've seen in people that ingest a substance in which you can have more of a prolonged syndrome is a complication from the substance itself, like serotonin syndrome, as you mentioned. We're not seeing the hyperreflexia, we're not seeing the hypertension, we're not seeing the clonus, we're not seeing a lot of the other signals of that. But the patient is receiving medication that we usually use to treat serotonin syndrome. So in particular, benzodiazepines. So maybe they are receiving enough of a treatment to hide some of the signs, but not enough of a treatment for their syndrome to get better. But I think entertaining all the threads that you guys already mentioned is where I would go next. And it's amazing like how profoundly this young patient is being affected. And so I'm really excited to learn more. So Deborah, please let us know what happened to the patient.
Great discussion. So an MRI of the brain was done and revealed extensive intraventricular hemorrhage, intraparenchymal hemorrhage on the right caudate, subarachnoid hemorrhage near to the right vertex, and diffuse axonal injury involving the splenectomy of the corpus callosum. So the patient was diagnosed with intracranial hemorrhage, diffuse, And some teaching points from the case that I learned that the ecstasy can induce the intracranial hemorrhage because due like a down regulation on the serotonin receptor associated with a vasoconstriction, being the globus pallidus the most vulnerable place that can happen, that because it's rich in serotonin. And we always like need to think about it as this patient had failed on the extubation. We always like have to think about it if could be something neurologic. And this case was from Ravi, like he sent to me. So I don't know how the patient did, but we can definitely take some teaching points from the case. So thank you so much.
Yeah, wow, Deborah, what a
Wow.
case. That was tragic for the patient. I wonder how he did in the end, and I'm worried about with this extensive bleeding. But Deborah, I'm curious if you know if he happened to have had a CT scan on admission, or never, because I feel like sometimes in the ED sometimes some EDs are pretty aggressive getting a CT scan, just when patient presents with mental status change, regardless of the underlying problem, or is there something that developed right from the beginning? I don't know if
I
you have the
don't have,
information.
unfortunately.
Yeah. Thank you for the case, Deborah.
Yeah, I mean, I think this is, well, like Austin said, I'm gonna have to rewatch and think a lot about this. I really struggled with this, and I think in retrospect, doing my own sort of cognitive autopsy, I was thinking maybe just putting too much into the stimulants, and frequently the CNS is just a secondary bystander to everything else that's going on. And in this case, without a focality, I think I really struggled to get there without the patient really having persistent symptoms and jumping to the CNS imaging earlier, and how that could have, led to a diagnosis sooner, and led to maybe some management changes. But yeah, I mean, I think the pattern of things makes sense, but the persistence is, I think should have triggered us. And I'm glad the patient got a diagnosis and they got the imaging that was needed. And I hopefully with reflection, I was able to do that sooner. I do wonder as well, and something I really should have thought about too in patients that are just really not returning to baseline is just the idea of potentially of non-convulsive status. And especially with all that hemorrhage, I imagine the patient's brain was just on fire, and had potential to just, have ongoing agitation with, some maybe vital sign aberrations that were very mild and masked by the sedatives. But yeah, what a case. And I'm going to have to think and learn a lot about this and read more about ecstasy and how it can affect things. But thank you so much for sharing, Deborah. Austin, what are your reflections?
Yeah, wow, incredible. And yeah, so much to learn, so much to take away. And I think, we started off with shortness of breath and chest pain. We got an EKG, and we were going down the route of looking into the PVCs and the ST segment changes. And then we see the patient and they're agitated and they have respiratory failure. In the end, like the problem that we should have been solving is encephalopathy, right? I think if we step back and say how many patients that are young that come to the hospital and are encephalopathic, or let's just step back and say any patient that comes to the hospital encephalopathic, they have an infection, they have a substance exposure, they have something else. Like how many of them do we actually image if we feel confident there's no trauma, or any other sign that they have a central nervous system infection potentially? I mean, very, very few in my mind. I know there's practice patterns differ everywhere else, but I'm not certain that if I saw this patient, got a good history and said, okay, this person has substance use, I would have imaged this patient on first pass. That being said, like, this syndrome probably wasn't necessarily present at the beginning of their presentation. Maybe there was signal and just got worse and worse and worse throughout the time. But really, really humbling. And I think if I think back to the patients I've taken care of in the ICU that were difficult to extubate, or their encephalopathy really just didn't improve after coming off of sedation, that's usually the scenario in which we're reaching for imaging. But at that point, it's too late, right? The devastation has already happened. So man, really, really humbling case. Really excited to go back and to listen again and to try to think through the problem. But really excited to see and hear shares his teaching points.
Sure. Thanks, Deborah, for this wonderful case and very wonderful discussion. So we were presented with a young patient who presented with acute onset of shortness of breath. And when we were first presented with that, we thought of the various cardiopulmonary causes of shortness of breath, like ACS, pulmonary embolism, pneumothorax. And Deborah immediately showed us an EKG, which showed us a lot of significant findings like bigeminy, premature ventricular complexes, and also ST depressions in 2,3 AVF, and also an ST elevation in AVR. So tying in all of these EKG findings with the patient's presentation, it was concerning for ischemia. And the patient did get troponins repeatedly, which ultimately came out to be normal. So that was kind of confusing. And so, like we always discuss on the CP solvers, any young patient presenting with symptoms of acute coronary syndrome or sometimes stroke or just about anything, we always have to consider bad genes, bad luck, and risky behavior. The patient was using ecstasy, and he developed a shortness of breath shortly thereafter. But like was mentioned in the VMR, that it's important not to just anchor on to the possibility of a toxidrome, but we also need to consider that it could also be a withdrawal. And so when we are dealing with such a situation, it's always important to do two things. A physical exam can help us tease out whether we are actually dealing with a toxidrome versus whether we're dealing with a withdrawal. And it's always useful to get some collateral information from bystanders. And it's also important to evaluate the vital signs, keeping in mind that the patient could have actually received some medications. For example, this patient was extremely agitated, and he had shortness of breath and chest pain, and he was getting a lot of sedatives and a maximum dose of sedatives, but his heart rate was still elevated, considering the fact that he was actually receiving these sedatives. So it's important to keep in mind that how the medications we are giving our patients can actually paint the overall clinical picture. And when we are talking about toxidromes, especially with drugs such as methamphetamine, it's also important to notice whether the patient has hyperreflexia or clonus on the physical exam. And very thorough wound and skin examination can also be useful to look for things like drug patches, or some certain injection marks. And also, when we're talking about chest pain, it's always useful to just activate the 4+2+2 framework. For cardiac causes are the life-threatening causes: aortic dissection, tamponade, Takotsubo, and ACS. And also the two pulmonary causes are PE and pneumothorax, and also esophageal rupture and impaction, just to rule out the most life-threatening causes, and then we can proceed further. And like we mentioned, the patient all had chest pain and persistently agitated, along with shortness of breath, and he soon thereafter developed hypoxemia and required intubation. And in this context, it was useful to get a repeat labs and also echo. And further testing showed he had a right lung opacity with ground glass, opacity with ground glass opacities, and there was also a posterior left lung lesion, and there was also profound hypoxemia. And in this context, considering the fact that he also was agitated and not oriented, and also he had lung injury, we would also think about the possibility of aspiration and subsequent lung injury. But the patient still persisted to have sympathetic overdrive. And now we were also trying to consider the possibility of thyrotoxicosis. And also we learned that it's important to get a thorough CNS workup, which ultimately led us to the final diagnosis. And also important to get review of medications and also consider serotonin syndrome. Although the patient didn't have the typical symptoms which we would expect in serotonin syndrome, like clonus and hyperreflexia, but again, the medications which the patient was getting could have possibly toned down all of these findings and made it a little more difficult to identify. So that's something to always keep in mind about how medications can impact the overall picture. And some interesting pearls which we learned in the chat was that hypercapnia can result in cerebral edema, and that's also something to consider, especially in the context of a patient having a high PCO2 and also some neurological symptoms. And the final teaching pearl, which I found was wonderful, was time is the best diagnostic test. And after doing a thorough CNS workup and getting the MRI, it was ultimately found that there was a diffuse intracranial bleed, which was possibly secondary to his drug intake.
Shreyas, amazing job. Thank you so much. And again, thanks everyone for coming. I struggled a lot, but I learned a lot too. And it's always great solving with you all. Have a great rest of your day.